Welcome to This Week in Neurology. This week we are covering 10 notable papers spanning acute stroke interventions, the complex genetic and pathological landscapes of neurodegenerative diseases, and practical clinical safety and measurement tools in neuromuscular and seizure disorders. Let us dive in. Our first theme this week takes us to the front lines of acute stroke intervention, focusing on how we can optimize outcomes during and immediately after endovascular thrombectomy. We start with a study published in Neurology that addresses a long-standing debate, the optimal anesthetic strategy during endovascular therapy. Traditionally, frequentist meta-analyses have suggested no significant difference in functional outcomes between general anesthesia and non-general anesthesia techniques. However, this new systematic review and Bayesian meta-analysis analyzed 10 randomized controlled trials involving over 1,600 patients with a mean age of 70 years. Using a Bayesian approach with weakly informative priors, the researchers discovered that general anesthesia was associated with a 94% posterior probability of superiority for achieving functional independence at 90 days, which is defined as a modified Rankin scale score of 0 to 2. Furthermore, general anesthesia was linked to a greater than 99% probability of superior successful reperfusion rates. This benefit, however, does not come without a cost. General anesthesia was associated with over a 4-fold increase in the risk of intraoperative hypotension and a 60% increase in the risk of pneumonia. No substantial differences were seen in 90-day mortality or symptomatic intracranial hemorrhage. While these findings suggest we should favor general anesthesia, clinicians must remain highly vigilant in managing blood pressure and preventing aspiration pneumonia during these procedures. Moving from anesthetic management to post-reperfusion care, a pilot randomized trial published in the journal Stroke investigated whether ischemic post-conditioning can mitigate ischemia reperfusion injury after successful endovascular thrombectomy. Reperfusion injury is a well-known phenomenon where the restoration of blood flow paradoxically accelerates tissue damage and infarct growth. In this single-center open-label trial with blinded endpoint assessment, 60 patients who achieved successful recanalization within 24 hours of stroke onset were randomized to either standard care or ischemic post-conditioning. The post-conditioning protocol was highly specific, consisting of 4 cycles of 2-minute balloon inflation, followed by 2-minute deflation, with the balloon positioned at the site of the original intracranial arterial occlusion. The primary outcome was infarct growth measured on magnetic resonance imaging at 48 hours. The researchers found that infarct growth was significantly lower in the post-conditioning group, with a median difference of -8.7 milliliters compared to the control group. Additionally, patients receiving post-conditioning showed lower infarct growth in early serial imaging and had significantly better neurological scores at 24 hours, with a median difference of 3 points on the National Institutes of Health stroke scale. Despite these promising radiological and early clinical findings, the 90-day functional outcomes measured by the modified Rankin scale did not show a statistically significant difference between the two groups. This pilot study provides proof of concept evidence that we can physically intervene to reduce reperfusion injury, but larger trials are needed to confirm whether this translates into long-term functional recovery. Our second theme explores the complex pathophysiology, genetics, and evolving therapeutic strategies in neurodegenerative diseases. We begin with a massive multi-ancestry genetic study of Parkinson's disease. Historically, our understanding of Parkinson's genetics has been heavily biased toward populations of European descent. To address this gap, researchers analyzed genome, exome, and array genotyping data from nearly 100,000 individuals across 11 genetically inferred ancestries, including over 15,000 individuals from underrepresented populations. The study found that while certain genetic contributors are shared, there are stark, ancestry-specific differences in both the frequency and spectrum of variants. For instance, causal variants in established Parkinson's genes were found in about 2% of the overall disease cohort, but this ranged from less than 0.5% in individuals of African ancestry to nearly 11% in those of Ashkenazi Jewish ancestry. Furthermore, risk variants in the GBA1 and LRRK2 genes were highly variable. GBA1 risk variants were identified across all ancestries but ranged in frequency from about 4% in East Asian cohorts to over 50% in African ancestry cohorts. These findings have massive clinical implications, particularly for ongoing clinical trials targeting GBA1 and LRRK2 pathways, highlighting the absolute necessity of ancestral diversity in trial recruitment. Remaining within the spectrum of synucleinopathies, a review in Nature Reviews Neurology critically appraises the brain-first versus body-first model of Lewy body disease. This framework helps resolve the clinical heterogeneity we see in practice where some patients present with severe autonomic dysfunction and sleep disorders years before cognitive or motor decline, while others follow the opposite trajectory. According to this model, body-first Lewy body disease originates in the peripheral autonomic nervous system, such as the gut, and spreads bottom-up to the brainstem and substantia nigra. In these patients, cardiac sympathetic denervation precedes nigrostriatal loss by nearly a decade. In contrast, brain-first disease begins in the olfactory bulb or amygdala and spreads top-down, meaning nigrostriatal tract degeneration occurs before peripheral autonomic involvement. Recognizing these distinct subtypes is poised to revolutionize how we approach early diagnostics, patient counseling, and the timing of disease-modifying therapies. In the realm of Alzheimer's disease, we look at the role of the glymphatic and vascular systems. A study in the Annals of Neurology evaluated over 2,200 participants across the aging and Alzheimer's spectrum to understand how magnetic resonance, imaging visible, enlarged perivascular spaces relate to vascular and Alzheimer's biomarkers. Using a novel quantification algorithm, researchers tracked perivascular spaces in the basal ganglia and the centrum semiovale, alongside white matter hyperintensities, amyloid positron emission tomography, and tau positron emission tomography. They identified three distinct patterns. First, perivascular spaces in the basal ganglia were strongly associated with both baseline white matter hyperintensity volume and faster progression of small vessel disease over time. Second, the longitudinal association between basal ganglia perivascular spaces and amyloid accumulation was weak and restricted only to individuals who were initially amyloid negative. Third, perivascular spaces in the centrum semiovale were not associated with amyloid or tau, but were associated with occipital white matter hyperintensities, which is a classic pattern of cerebral amyloid angiopathy. This suggests that basal ganglia perivascular spaces are a robust early biomarker for progressive small vessel disease, rather than a direct driver of classic Alzheimer's pathology. On the therapeutic front for Alzheimer's, Nature Medicine published a Phase 1b, randomized double-blind trial of a novel immunotherapy targeting neuroinflammation. While current monoclonal antibodies target amyloid clearance, this trial investigated IBCA-FLAT002, a short-lived anti-programmed death ligand 1 antibody designed to temporarily boost the systemic immune system to help resolve local brain inflammation. 40 participants with early Alzheimer's disease were randomized across 5 ascending dose cohorts and received 4 doses at 3-month intervals. The primary focus was safety, and the drug was well tolerated with no serious treatment-related adverse events, and notably, no evidence of amyloid-related imaging abnormalities. Although the trial was not powered for efficacy, exploratory analysis at week 48 showed directional improvements in cerebrospinal fluid biomarkers of neuronal and synaptic damage at the highest dose of 30 mg per kilogram, though these did not reach statistical significance. This safety profile is highly encouraging and supports the continued clinical development of this novel mechanism. Our final theme covers safety, efficacy, and clinical measurement tools that directly impact our daily outpatient practice. We begin with a critical safety study. Stevens-Johnson syndrome and toxic epidermal necrolysis are rare but life-threatening conditions associated with several anti-seizure medications. Using Danish nationwide registries spanning nearly 30 years, researchers tracked over 1.3 million initiations of 25 different anti-seizure medications. They identified 83 cases of these severe cutaneous reactions within 90 days of drug initiation, with the majority occurring in the first few weeks. The severity of these reactions was highlighted by a 17% one-year mortality rate. The study calculated precise absolute risks, finding that lamotrigine carried the highest risk at approximately 29 cases per 100,000 initiators. This was followed by carbamazepine at roughly 17 cases, phenobarbital at 16 cases, oxcarbazepine at 11 cases, and valproic acid at 7 cases per 100,000. In contrast, the risk was substantially lower for gabapentinoids, with pregabalin at about 2 cases and gabapentin at 1 case per 100,000. No cases were observed with several of the newer agents, though overall exposure was lower. These precise numbers provide an invaluable reference for clinicians when discussing risks and counseling patients who are starting new anti-seizure therapies. In the neuromuscular clinic, we face similar challenges in balancing efficacy and safety when treating generalized myasthenia gravis. A Bayesian network meta-analysis in neurology evaluated 27 placebo-controlled randomized trials involving over 2,300 patients to compare the efficacy and safety of novel therapies. Because head-to-head trials are non-existent, this analysis compared neonatal Fc receptor inhibitors, C5 complement inhibitors, and CD19 B-cell depletion therapy. The researchers found that all three classes demonstrated comparable clinical efficacy, with similar reductions in both the quantitative myasthenia gravis score and the myasthenia gravis activities of daily living score. However, a key differentiator emerged in the safety profiles. Patients treated with neonatal Fc receptor inhibitors had more than double the odds of experiencing treatment-related adverse events compared to placebo, whereas C5 complement inhibitors and B-cell depletion therapy showed adverse event rates comparable to placebo. Additionally, sensitivity analyses suggested that age and sex differences across trial populations could confound these results, highlighting the need for future prospective, head-to-head comparative trials. For patients with medically refractory dystonia, deep brain stimulation remains a highly effective but variable treatment. A review in the Lancet Neurology highlights how advances in neuroimaging and neurophysiology are moving us toward network-based personalized care. Dystonia is increasingly understood not as a disease of a single brain region, but as a network disorder involving abnormal interactions across cortico-basal ganglia cerebellar circuits. By utilizing non-invasive neurophysiological techniques, intraoperative recordings, and connectome-based neuroimaging, we can map how deep brain stimulation modulates these distributed networks. Integrating these clinical, genetic, and connectivity profiles will allow us to better select candidates and customize stimulation parameters to improve individual clinical outcomes. Finally, we look at a new clinical tool designed to measure disability in chronic idiopathic axonal polyneuropathy or CIAP in a study. Researchers developed and validated the CIAP-RODS, which is a patient-reported Rasch-built overall disability scale. Historically, there has been no disease-specific patient-reported outcome measure to capture functional limitations in this population. Starting with a massive pool of 196 potential items, researchers worked with patient advocacy groups and analyzed responses from 268 patients. Through rigorous Rasch analysis, they refined the tool down to a final 24-item scale. The CIAP-RODS demonstrated excellent test-retest reliability, robust internal validity, and correlated strongly with established general quality of life measures. This practical 24-item scale is highly recommended for use in future clinical trials and routine clinical practice to accurately track disease progression and functional limitations in patients with chronic axonal neuropathy. If you only have time for one paper this week, make it the Bayesian meta-analysis of anesthesia strategies during endovascular thrombectomy for acute ischemic stroke. This study challenges the long-held clinical assumption of equivalence between general anesthesia and non-general anesthesia, showing a 94% probability of functional superiority and better reperfusion rates with general anesthesia, which should prompt stroke teams to actively re-evaluate their peri-procedural protocols. Here are the key takeaways from this week in neurology. First, general anesthesia during endovascular thrombectomy for acute ischemic stroke is associated with a high probability of superior functional independence at 90 days and higher rates of successful reperfusion compared to non-general anesthesia, despite a higher risk of intraoperative hypotension and pneumonia. Second, when initiating anti-seizure medications, be aware of the specific 90-day absolute risks of Stevens-Johnson syndrome and toxic epidermal necrolysis, which are highest for lamotrigine at nearly 30 per 100,000, but extremely low for gabapentinoids like pregabalin and gabapentin. Third, in generalized myasthenia gravis, neonatal Fc receptor inhibitors, C5 complement inhibitors, and CD19 B-cell depletion therapies offer comparable clinical efficacy, but Fc receptor inhibitors carry more than double the odds of treatment-related adverse events. Fourth, ischemic post-conditioning via temporary balloon inflation after successful stroke recanalization is a promising approach to reduce infarct growth, though it does not yet have proven clinical benefit at 90 days. And finally, the newly validated 24-item CIAP-RODS scale provides a robust, disease-specific tool to measure and track disability in patients with chronic idiopathic axonal polyneuropathy. That's your roundup for this week in neurology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.